I'm going to turn things over now to John Roeske and his group. Let me just, there we go. John, it is all yours.
Okay, thank you. Thank you for having us here. I'm with my colleague, Jen Magliari, who's a dosimetrist, and we're going to kind of tag team on this presentation. I'm going to talk a little bit first about what are the elements of a clinical quality assurance system for contouring. And Jen is going to give a specific example that she was involved with our dosimetrist looking at contouring normal tissues for prostate cancer. So when I was preparing for this presentation, I was trying to Google and find out a little bit more about quality assurance. I mean, I think we all kind of inherently know about quality assurance being in radiation therapy, but to find out exactly what people define as quality assurance is something that's actually quite interesting. And here are a few of the thoughts I found on these. Interestingly, most of the sites that I found were not from the United States. They were from Japan and other countries. So I think that kind of lets you know what our current thinking is of quality assurance here, unfortunately. But in terms of what's needed for a quality assurance system or what people recommend, one is that you need a standard. What is it that you're going to compare your measurement or your result to? You then need to carry out an assessment and figure out how well you're doing, how well you're agreeing with that standard. And then based on your results, you need to create an action plan. Do you modify your what you're doing based on your results? Do you continue going? Are you doing well? These are all the questions that kind of come out of that. Once you develop your action plan, you then need to implement it, and then finally you need to do an ongoing review. So here's an example that certainly all of us in the radiotherapy community are familiar with, doing our daily output checks on the LINAC. So our standard is our calibration, which was established generally by the physicist at the time of calibration. Generally, we perform the assessment daily. If our results are outside of tolerance, we may contact a physicist, or we may look at our equipment, make sure that our setup is correct, that the equipment is turned on, maybe some very basic, simple things like that. Or if we can't solve the problem immediately, we may want to hold off treatment on a particular machine. And then we identify the issue to correct the problem, whether it's a miscalibration or, again, if it has to do with our equipment or usage of that equipment. In contouring, it's a little more difficult. Some of the questions, and I certainly don't have all the answers for this, but I have a few thoughts, is, first of all, how do we establish a gold standard? And we just had a very good discussion of how that's done, certainly in prostate cancer. And I think in defining these gold standards, particularly in the future, having very well-defined written guidelines are certainly something that's going to be very important. The other issue is how reproducible are contours among individuals, in a sense that comparing an individual with themselves. So, for example, as you'll see in the upcoming study, we ask our dosimetrist to contour the same patient twice, because you can imagine some days maybe you're rushing to work, you're a little jiggly, you had a lot of coffee, maybe your contours are not the best compared to other days. So this is certainly an important area to assess here. The other issue is, how good do our contours have to be? Do they have to be perfect? Do they have to, what is good enough, basically? And I think that's something that we need to decide upon. Certainly our contours are not always going to be perfect. I mean, we're human beings, and we have, there's certain limitations in terms of contouring software and other things. So one of the questions in looking at the contouring system is, how good do we have to be? And then lastly, what is our frequency of assessment? When we design a quality assurance system, we can't be doing quality assurance throughout the day, obviously, because we would never get our work done. But we need some reasonable time frame in order to assess things. So here's an example of a flow chart that we designed for a clinical quality assurance system. Jen Magliari is actually the person who designed it, and she'll talk a little bit more about the implementation. But we tried to incorporate each of these different elements into it. So, for example, establishing the gold ROIs, we looked at having a radiation oncologist and a radiologist review the contours together. We have a box here where dosimetrists would draw repeat contours in order to verify or quantify any intradosimetrist variation. Down here, we have the assessment box where we compare our contours that our dosimetrists have drawn to the gold ROIs drawn by our physicians. And also, we try to quantify the relationship between these metrics and some dosimetric endpoints. And then finally, the review portion, whereby the dosimetrist can go back now and review their contours relative to the physicians drawing contours, the gold standards, and get some feedback on how well they're doing, and use that for future future learning and future contour drawing. So I think one of the questions that we certainly want to ask is this a problem? And this is an example that Greg Robinson provided for me. This is from the ROI GYN Plan Challenge. And this is just showing the variation in drawing the rectum in a single GYN patient, and the variation in the dose volume histograms coming across between these. So you can see that contouring certainly is very important, and even relatively minor changes of contouring can have significant variations on the treatment plan. So with that, I'm going to turn the presentation over to my colleague, Jen Magliari, who will discuss what she has done.
Okay, so our first step here was to get two people involved. The person who is in charge of most of our GU prostate patients, and additionally we thought it might be a good idea to get someone involved who looks at regular patient anatomy every day, which was the radiologist. So we had the radiation oncologist go ahead and delineate bladder, rectum, prostate, and both left and right femurs. And then we had the diagnostic radiologist go through and review it, make sure there's no changes that needed to be made. If there were changes, they both had to agree upon them before it went on to be called the gold standard. Next, we had each of the dosimetrists all contour once just the bladder, rectum, and left and right femurs just for the initial set. They didn't have a timeline to do this in. It was just supposed to be basically on your honor, use the approximated time that you would use to contour any prostate plan. Approximately a week later, they were asked to do the same scan over again, and we were going to evaluate the differences. And we were asked them not to go back and review what they did the first time. I mean, in some cases it was more than a week later. Hopefully they had forgotten about it and had been thinking about the different prostates they'd contoured in between. We sent both of them through to the structure software and came up with some different metrics. We used the dissimilarity coefficient and came up with some of our own metrics, which we'll show you a graph of here in a second. I think so. So here is the penalty that we came up with. There was a few different just standard penalties that come with the software, but it gives you the freedom to design some of your own. So we thought in most cases that if your contour is within a millimeter of the gold standard, that you shouldn't be penalized for that. So what we did is we gave a 0 penalty for anything within 1 millimeter, and then exponentially from there on out, your penalty increased. For example, if you were 4 millimeters away from the gold standard, your penalty score was 4. So, yeah, go ahead. So here's some scores that we got. Basically, this is the intra-dosimetrist scores. So their scores are really pretty good. It seems like even the student who doesn't maybe have as much experience didn't really differ from his original contours to a week or more later, and it just gave us the answer that basically no matter, it doesn't say that it's right or wrong, but typically consistent with what you see is what you see. So we just went ahead and compared the gold with the different volumes of structures. So we did the rectal and bladder volumes, and the average is the dotted line in between there. And you can see that the volumes do fluctuate quite a bit, ranging from low 50s to low 60s, which, I mean, the graph makes it look probably worse than it is. But when we took those and dropped them on the plan, it wasn't a huge dosimetric significance, even though the volumes were, considerably different. So there's a slide of the bladder volumes as well. And you can see that the average is almost right in line with what the gold is. So we thought that was interesting too. So I just have a few charts here of basically mean doses to metric scores. We were trying to see if there's a linear similarity or some sort of linear function between scores and dosimetric endpoints. And you can see here there is some that we establish on both bladder mean doses and rectal mean doses. Limited, but some. So here's just a screen capture of basically the gold versus one of the times that a dosimetrist drew. So where it's green is where there's a common outline between gold and what the dosimetrist drew. So you can see that where it's blue is where it's missing. So the gold actually encompassed much more posterior than the dosimetrist had contoured. So what we did here is we sat down each dosimetrist and gave them the opportunity to look at this visually where their contours overlapped with the gold contours, and gave them the opportunity to then, after reviewing the gold versus their contours, give them the opportunity to contour once again. So after they contoured once again, you can see that the red scores are scores that actually decreased, and the green score is a little bit increased. But we found, and there's probably a few different reasons for this, but we found that the scores may have decreased because probably memorization. I mean, when I sat down and did it, and when I sat down with the other dosimetrists, we were counting, okay, the gold contour was 3 slices below what I thought was gold, so I'm going to draw it here. So when you're left to memorize what you think was right, you actually did worse than just going with your natural instinct of what was correct. So basically what we've determined was that the best way to do it is maybe not use the same scan after you've been, looked at the gold contours versus what you drew the first time. Maybe you try a different scan and see if those scores are the same as what you had before, if not better. I mean, our scores were reasonably good, so we weren't really sure if improvement was necessary and how much better can you really get and how good is good enough. So dosimetrically, our endpoints weren't significant enough to say that anybody really was outside of tolerable. So we were thinking in the future to use multiple scans for assessment and basically use the same scan for intra-dosimetrist, but then use multiple scans to see if there's improvement. We want to also do other sites. This study was so small because it only had 5 of us dosimetrists and only bladder, rectum, and femurs. So we think we'll have much more interesting results if we use head and neck, thorax, brain. So we're excited to see what correlations we can make between those scans and dosimetric endpoints. Thank you.
All right. Thank you so much. That was a really great presentation. I don't see any questions at the moment for the group out of Loyola, so what we'll do is we'll keep on moving here. Please, if you have any questions, send them in, and we'll answer them as they come up, basically in order that they come in during the Q&A session after Ben gets done here. So with no further delay, I'm going to transfer things over to Ben Nelms. Now has the presentation ball.